Our next speaker is Dr. Pramod Jacod, who's a physician health informatician. I knew this was going to be a tongue twister, with over 18 years of experience in the field. He joined dWise Healthcare IT Solutions Bangalore as the Chief Medical Officer and has been instrumental in designing dWise's Lifetrenz, OP and IP EHRs, and clinical information systems for the Indian healthcare scenario. Dr. Pramod's experience spans across the US and healthcare organizations in South Asian region, with project management, implementation, and change management being his special areas of expertise. At present is involved in a Wellcome Trust-funded project with the Public Health Foundation of India and the London School of Hygiene and Tropical Medicine for the development of chronic disease database with clinical decision support integrating mobile and Bluetooth technology. Please welcome Dr. Pramod Jacod.
Thank you for the introduction. Is it working?
Yes.
Or maybe I don't need it. I have a loud voice. Testing, testing. Okay, there you go. Thank you for the introduction. Ladies and gentlemen, hopefully you're not feeling hungry enough and can pay a little attention to what I have to say. My topic is electronic health records and maintaining the continuum of care. It is a rather hot and I think getting to be a very important aspect that I'm trying to cover out here. So, sorry, where is the slide changer? There you go. All right. Hopefully this works. There you go. Okay. The topics I'd like to cover are, what are the advantages of going electronic in the entire healthcare information scenario, differences between the EHR and the EMR, some principles of the continuity of care, what is the facilitation that the Government of India and the Ministry of Health are doing towards going electronic in healthcare information, and the challenges in deploying EHRs in India. So, let me begin with firstly trying to explain advantages of going electronic. It's very simple. An electron can go around the world in 19 seconds. Basically, if I was to walk from here till the gate or till the gate of this hotel, that same information or any piece of information can go around the world in that much time. You can't compare paper with that, right? Taking a piece of paper from here till the gate, in that much time, that same information can go around the world if you go electronic. So, to achieve speed, it is extremely important to harness information technology. To get reliability and to also get accuracy, it is best if this information is fed into a system or a system in which the caregivers or the providers of care directly put in that information so that there is nothing lost in translation if you have somebody else like a data operator doing it. Hence, healthcare information technology. So you have all these advantages, speed, validity, and reliability. And the other big advantage, multiple providers or caregivers can look at the same information on their terminals, on their tablets, or whatever, because unlike a piece of paper, it is not geographically dependent on everybody being in the same location. In different locations, you can actually view the same information. The next thing is, if you gather up all the information of a patient across points of care, you can actually make what is known as a longitudinal record, from birth till death. It's possible. And that, ladies and gentlemen, is 21st century healthcare. So, I'm now trying to get into explain the difference between what is an electronic medical record and electronic health record. It's a rather tough concept to get through until I came across something that's parallel. All of us have come to the end of the year, so everybody knows about taxes, right? And we all know about tax deducted at source. So, since we are probably returning filing our returns, I thought this would be a good sort of parallel to what I'm trying to explain out here. There is a form for tax deducted source called Form 16. It happens to be my Form 16. Of course, I have kind of made sure that the sensitive information is covered. I didn't realize I was on national TV. Anyway, as you notice, in this particular form, this is a declaration by my company who's paying me a salary saying, this is how much we have paid Pramod this year, right? And out of this, this is the tax that we deducted from his salary and have paid into the income tax department or to whichever concerned authority. Now this, from the point of view of my company, is how much is the tax deducted from me and my payment for Pramod. But is this my entire story of how much payment I have received and how much taxes were deducted? It is not. Because I'm also a freelance consultant. I also have deposits in the bank, which has earned interest, and on which tax has been deducted, correct? So then we have to collate this information, which in this case of India, there is a form 26AS. What this does is, this part actually collates all the payments I have received and what is the taxes that has been deducted at source from each of these payments. If I was to take a parallel of this into healthcare information, the previous form, Form 16, would be an electronic medical record of a given healthcare organization about the sort of healthcare transactions that they've done with me, or what is the healthcare they've provided to me. But that may not be the entire healthcare picture for me, because I might have been going to different doctors over the years, and therefore receiving different point of care treatments. And that is what an electronic health record is. Basically, collating all the healthcare transactions that have happened to me into one record. This is an electronic health record. Hopefully, I've been able to explain that. I know tax is something everybody's aware of, so I've hopefully been able to get that point through. So how was this done? Just like the government of India makes you now fill up these TDS forms into one centralized database, you have to have some sort of concept similarly. So what you have is different sort of electronic medical records feeding into your electronic health record, right? And you use different forms of data exchange. It is called interoperability, whereby the information from one system is fed and received into another system. There are various standards in place. There's something called HL7, which helps in basically this exchange of information. And also, a lot of new sort of paradigms are coming. There's something known as FHIR, FHIR, Fast Healthcare Interoperability Resources, whereby APIs are sort of used because they found that an easier way of exchanging information. A lot of work is still in the draft stage, FHIR, but it is the way forward. Sorry, let me go back one more thing. So, therefore, what you do is you collect all my longitudinal record into my electronic health record, and then on that longitudinal record, it's the best for things like analysis of my health outcome or coming for clinical decision support. In case a drug that was given by one provider is going to react with a drug from another provider, it is best I do it in the electronic health record, because there the entire list of my drugs will be in place. So this is an important concept to understand, why electronic health records vis-a-vis electronic medical records. So what are we trying to achieve? This happens to be our electronic health record. What I've done is basically, on the 11th, there was a visit I did to a Dr. X, who happens to be working in Y hospital, in Y OPD. He had a look at me, and he decided that I have to be referred now to Dr. X from another hospital, where I've gone to go and visit the next day. So on the 12th, I went and visited Dr. X. It is, Dr. Test. So Dr. Test has gone to now see me, because I was referred from Dr. X. It is important that Dr. Test sees what was the events and what exact transactions happened, or what exact information took place, or what sort of healthcare was given to me by Dr. X in the previous visit. So therefore, what we do is we collate all this information. You select a particular date, and for that date, you will see what is the various sort of vitals that was taken, what are the medications given to me, what was the basic diagnosis that was come across, what was the lab orders, and so on and so forth. So just like Form 26AS, where I can actually take and expand a particular tax details, I should be able to expand a given visit to any of the doctors where I've had or any of the healthcare providers where I've had some treatment, and details of that should be able to be seen. This is what we are trying to achieve, right? So then finally what you do is you have like a balance sheet, you have a patient summary in which all the medications I'm getting from across all my healthcare providers, all the sort of lab tests that have been done recently, and all the sort of vitals that have been taken across these healthcare providers are put into a summary page, thereby giving a balance sheet of what my healthcare status is today. This is possible if we go electronic with standardization in place and with interoperability. So, therefore, what happens? If I'm a hypertensive patient, the different readings taken across the different points of care will therefore actually be able to be brought together and a trend seen. Am I in control? Am I not in control? For example, in the beginning here, I was out of control. I got it into control. Then I probably went out of town, again got out of control, probably went to another doctor there who has basically logged in my readings. And then when I come back home, the doctor who's my normal doctor can see the trend across, even though I have been somewhere else or to another doctor, right? Very important, and this is the point of continuum of care. For something like, especially non-communicable diseases, like diabetes and hypertension, it's a very important concept because it's a long-term care that we have to look at across the board. So, I want to talk a little bit of principles of continuity of care. Countries which are supposed to be very efficient in the healthcare, that means getting the best outcomes for the biggest bang for the buck, or for so much of money, you're getting so much of good outcome. The countries that are supposed to be leading in such parameters are UK, Denmark, and Canada, for example. The US is not up there. In fact, the US is something like 24th or 26th in the world. Even Cuba is supposed to have better sort of outcomes and more efficient systems. What is the common factor that we find in these countries is the fact that they have a very good primary care system whereby there is maximum involvement with your main doctor, your primary care doctor, and if you have a problem which he cannot handle, he refers you up to secondary, tertiary level and so on, right? And we also find that in these countries, there is a very good healthcare IT system in place, and where especially the primary care doctors are logging in all the events and all the sort of encounters that happen with you. For example, in Canada, it's something called Canada Infoway. In UK, there is something called the UK GP IT services. So it's been proven that this works. What is the actual flow of healthcare information? If we had a system whereby we had this pyramid of whereby your maximum visits happen to your primary care doctor, your family doctor, primary care doctor, right? In case he has to refer you up to a secondary or tertiary care, he will be sending up information like your patient summary, your patient longitudinal records, and he might be asking for a referral also. This patient has a murmur. Can you please tell me what is the possible diagnosis, what we should do? He'll send me to a cardiologist. Correct? So when I go up to the secondary and tertiary level, to the cardiologist, it is important that the cardiologist know what has been happening with me in my visits to my primary care doctor or to my family physician, right? And then, depending on the trends that he sees across a period of time, he can take a come to a much better conclusion of my possible problem and therefore recommend better interventions, especially in cases like hypertension, diabetes, which will complicate other comorbidities that I might have. There is also information flowing from the tertiary to the primary in the way of discharge summaries and referral responses, right? But the majority, what we'll find in countries like Denmark and Canada and all that, is that the majority of information is actually going upwards. It is more important for the tertiary level and secondary level doctors to know what is going on in the primary care. It is extremely important, because then you have correct trending and a correct diagnosis come to and correct sort of interventions planned out. Similarly, the information going down to the primary care is also important for continuing and making sure that correct treatment and interventions go on. So, how do we do this? I'm giving an example of very basic primary care electronic medical record, electronic health record that we have. So Dr. Pramod Jacod is right now seeing a patient, Tess David, and I happen to be actually logging in the information that happened in this visit of his. And then he tells me, doctor, by the way, I was in Bombay. I've come to Bangalore to meet you, but I was in Bombay where I had another doctor who also uses an electronic health record and who has also been seeing me for the last so many months. Or maybe he went out of town that one time. He's normally my patient. He went out of town, and when he went out of town, he had an event, and therefore he saw a doctor. Now that doctor also happens to be an electronic health record, right? So how can I get this information sitting in Bangalore from the person in Bombay? What I do is I call him up, and I ask him, can you please send me this record? Because you're also using an electronic health record. Please send it across to me by email or by whatever sort of mechanism we have. Even an email would work. What I will do is, you see this import CCD. I will talk more about what CCD is. It is continuity of care document. Once he sends me that email, I would press this import CCD, and what happens next is, if you are using a system that is standards-based and interoperable, you will have that information from the other doctor actually coming into the system through this continuity of care document and with standards in place. For example, if there's a diagnosis, that diagnosis would be in ICD-10. Okay? If there's a lab, it would be in something called a line code. And the reason for standardization, I will explain a little later. So then this comes in, and then I will be able to include this particular record or whatever happened in that visit into his record or electronic health record that I have maintained for my patient. So you therefore have the longitudinal record across points of care coming into a consolidated sort of a situation. I'm trying to change this. It's not moving. There you go. Okay. Really just explaining what do we mean by these various sort of interoperable documents and all. There is something known as CCDA, which is the Consolidated Clinical Document Architecture, which is a standard by which they have the various documents. Actually, there are about 9 documents, templates that are there, where they explain what each of these documents should be having as content. For example, if it is a CCD document, it should have allergies, medication, problem lists, and so on, right? So that's what should be in the body. So HL7 is a way of how you will have the container or the envelope. What is inside the envelope is described by this CCDA. That's what it is basically. But these standards are in place, and in fact, the government of India has been encouraging us to use it. So if we look at the 12th five-year plan, it has been mentioned there that primary care is going to be definitely taking importance. I've even heard the Honorable Health Minister mention this in Delhi when he actually came for the family, All India Family Practitioners Conference. And they are going to give primary care importance, and it is going to be the gateway for secondary and tertiary care. At least that is the aim with our universal health access and programs. So then health services should be delivered seamlessly from primary care on to secondary and tertiary care, and with it, the healthcare information that is involved also should be flowing up and down. And that will lead to networks now, whereby you will have primary care, secondary care, and tertiary cares in panels, including electronic sort of highways for them, right? So this is already part of the 12th five-year plan. What they are helping and facilitating is, for example, these are the standards that are now already published for healthcare information technology. If I was to send across, say, something called a lab test result, it would have to be in a standard called LOINC. If I had to send across a diagnosis, it would have to be in something called ICD-10 or SNOMED, right? And if I was therefore to send across the patient identification, they say, please send across the Aadhaar number now. Now, why standardization? Let me explain. Firstly, medicine has got different terminologies for the same concept. If you look at diagnosis, tuberculosis is one sort of terminology for TB, but so is Cox disease, right? If you look at labs, fasting blood sugar is one concept for one test, but it's also can be called FBS or called fasting blood glucose by another provider. Again, the same concept. I want to take this person's blood sugar before he has something to eat or before his meals. By having standards in place, you make sure that these different terminologies have the same code at the back or concept ID at the back. There's something called SNOMED for clinical findings. For example, and especially in India, for the concept of fever, in English itself we have pyrexia. In Hindi you can call it bukar, right? In Tamil you call it jaram. The same concept, different languages. How do you get to a central computer to understand that this is the concept of increased body temperature? By using standards like SNOMED or ICD-10. So that is the real importance of using standards, which is the first stepping stone you need in place for any information technology system or healthcare information technology system, so that two computers will understand each other. Otherwise, if you have two computers and you say fever in one and pyrexia in the other, they'll think they're different sort of concepts. So that is the importance of standards. It took a long time for healthcare information technology and its medical informaticians to come to an agreement about these standards, but it has been in place, especially since 2009. A lot of movement and success stories have been there. So if we do this on an individual patient level, then what we do is, when you actually have a population, say even a small, start off with just a district, or start off with just a city or a district, and have all the patient records, hopefully as electronic health records, and then I say, okay, I want to see what are the top 20 diagnoses in this district. At once, with a click of a button, a couple of parameters filled up in a click of a button, you will get to know what are the top 20 diagnoses. I further want to see, okay, now I want to see the most common diagnosis. I drill down, I can drill down and see who the patients are. And then if I want to actually now see different trends, what is the relation or association between acute respiratory tract infection and acute pharyngitis across 2 years? I can at once build up get a output which shows if there is an association or relation, which in this case happens to be so. So again, the power of going electronic. Now, we have been having challenges. Give me a moment here. It's not going back. Can you just press one back? Can you press? Okay, there you go. So the challenges that we've been having about trying to get this technology in place and electronic health records going, firstly is acceptance, especially by the healthcare providers. It is not easy. You are changing from folks who have been used to using paper for the last 2,000 years, and you're asking them to do all the work on the computer or on a tablet. So there is change management, and there is a lot of work to be done for getting them to accept it and adopt this technology. It does need top management support by the healthcare organizations and by the powers that be in, say, the Ministry of Health and so on. In India, there is a lot of movement happening by the Ministry of Health, at least central, at the center. The states have to now come on board also. You need EHR systems to be standards compliant for the reasons I've explained, right? If you start with that basic stone so that the diagnosis can be understood by different systems, so that whole stepping stone has to be adopted. And then, whether you want to go in for something like an integrated health information platform, which may be a little too much for us with a 1.2 billion population, or do we do subsets in a distributed sort of service, sort of a way of collecting information from different parts of the country, or whether you make each person's record a potential collating longitudinal record, which is what the US is doing right now. Instead of having some central database collecting all the information, each person's record has the ability to collect the information about that person across different points of care. It's a little more detailed if I have to give you the explanation for that, but basically that's the concept, and these are the challenges we face. But there is a lot of positive movement happening. For example, the state of Tamil Nadu has actually gone quite electronic, even in the government systems. They have started the CHC, the community health centers, and through the district hospitals, they have almost fully electronic. How much is how well adopted, that studies are being done, but there is movement happening. Thank you.